Yeah, so this is data and connectivity, COVID-19 vaccines pharmacovigilance. This is a project that enables us to study COVID-19 vaccine safety and effectiveness using national data sets across the UK. So we have a number of partners working on this project that you can see here across Scotland, England, Northern Ireland, and Wales. And I'm just going to briefly try and acknowledge our team. I can't do them all individually, unfortunately, because there's too many, but they've all been doing really fantastic work on various COVID-19 related projects over the last more than a year now. So the data we have access to, we have GP records, we have hospitalization records, we have mortality data, vaccination data, and testing data. And our coverage is the whole of Northern Ireland, Scotland, and Wales, and roughly 10% of England. So all of that information is stored anonymously and in highly secure, trusted research environments. So we've had patient and public involvement and engagement built into everything that we've done from the start. So the basic goal here is to understand questions that the public are most interested in having answers to. And we've, to that end, approached various advisory groups and underrepresented communities. And something that's come out of that, so they've tended to have very high confidence in vaccine safety. There's lots of concerns over long-term impacts of COVID-19 and long COVID, as well as lots of questions about booster vaccines and mandatory vaccines for work and for travel. Something really great that's come out of this is that they requested we produce lay summaries of our published work, which we have done. So if you go to the EVE2 section of the Usher Institute website at the University of Edinburgh, you can see lists of our published work alongside sort of plain English summaries of what we did and what we found. So onto our actual findings. So we did a study of blood clot related adverse events in Scotland. So this is between the 8th of December 2020 and the 14th of April 2021. And the main thing that we found, so we looked at Oxford AstraZeneca and Pfizer. We found a small increase in risk for some adverse events for Oxford AstraZeneca, but not for Pfizer. And the main finding we had was for ITP, which is essentially low platelet counts in the blood, which can sometimes lead to, in certain cases, it can lead to bleeding in the head, and that can be potentially be fatal. So what we found was an equivalent to an additional 113 cases for every 10 million doses of Oxford AstraZeneca administered. Okay, and so we have some work in progress just now. So it's a pooled analysis of CVST across England, Scotland, and Wales. So CVST stands for cerebral venous sinus thrombosis. It's a type of blood clot in the brain that causes stroke. So it's a very rare and very serious adverse event. So approximately 3 to 4 incidents per million people each year. And what we did was we compared the rate of CVST in the 4 weeks following vaccination compared to a baseline period. So we found a slight elevated risk of CVST, so roughly double what it normally is in the 4 weeks following vaccination with AstraZeneca. We didn't find an elevated risk for Pfizer, but we can't rule it out with a high level of confidence. So the last thing I want to talk about briefly is just risks and benefits. So the broader risk and benefits associated with vaccination. And I want to sort of break this down into individual level and societal level. So by individual level benefits, I mean, what are the consequences for me of being vaccinated or not? So I think we have good evidence now that COVID-19 vaccines have a high level of effectiveness against COVID-19 hospitalization and death. So if you take the vaccine, you are statistically less likely to end up in hospital or to die from COVID-19. But there is some evidence now of waning in effectiveness over the course of several months. We've also seen some evidence of increased risk of adverse events after vaccination, depending on which vaccine and which adverse event as well. And we've produced some evidence on that. And the other thing to keep in mind is that COVID-19 hospitalization and death is very unlikely in younger and healthier populations. And so as you get younger and healthier, the balance, at least from the individual level, appears to go further against vaccination, at least with some vaccines. At the societal level, so what do I mean by this? I mean, what are the costs and benefits to other people of my decision to get vaccinated or not? And so I think a primary question here is, does being vaccinated actually reduce the chance that you will transmit the infection to someone else? And that's a very interesting open question. So there's recently a study came out using data from the UK on this. So they studied within household transmission, and they found that unvaccinated people and vaccinated people were roughly as likely to transmit the infection to others within the same household. But it's a very difficult thing to study, and more evidence is needed in there. There's also a potential reduction in healthcare burden. So if I'm less likely to end up in hospital, then I'm less likely to put a strain on our healthcare services. Some other considerations is naturally acquired immunity superior to vaccine acquired immunity. So there's been a recent study in Israel that suggests that was the case. So I think they found something like people who were double vaccinated were 13 times more likely to be reinfected, sorry, not reinfected, but to be infected compared to people who previously had an infection and recovered from it. And then finally, so Nature did this poll. So Nature is a very prestigious journal, and they did a poll of COVID-19 immunologists and virologists. So 89% of the people who were surveyed thought it was likely or very likely that COVID would become endemic, like, for example, the flu or the common cold. And if so, should we move towards a more targeted vaccination program, so something more akin to what we do with flu every year. So it's very difficult to weigh up all of those considerations, and there are many questions that we can't really answer with a great degree of confidence, but nonetheless, decisions do have to be made with what limited information we have. So one policy that the UK has pursued is restricting administration of vaccines in certain age groups. So we restricted Oxford and AstraZeneca to only those aged under 40. Various Scandinavian countries have recently suspended Moderna for people aged under 30 over myocarditis. I think France has recently done similar. So these are sort of policy responses that we've either pursued or other people are considering. So yeah, that's it from me. So some quick acknowledgements, and that's it.
Great.